Hello, I'm Mark Bogdanov, your instructor, and also the moderator of a special feature that you're about to watch. This is a select panel of representatives from a variety of health agencies or agencies concerned with community health. And I would hope that you would listen intently and then continue the discussion with your discussion assignments in the course, and also to carry the message out into the general community, contacting your elected representatives and political candidates to bring your expertise to bear on the health of the community. I should start off with myself. I've been in public health for a number of years. I'm a registered dietitian, and I've worked in public health mostly in maternal and child care, and also in on the patient care side too, as a dietary director for a small hospital. And I've also taught in the public schools and taught health education in the public schools. So I kind of have a well-rounded view of the healthcare scene and the public health scene, and have an idea how they fit together. And I think the students will have more of an idea too if we all share our stories, maybe starting with Deb Loy, and if you could each introduce yourself to the students. And
Certainly. Well, my name, as I said, is Deb Loy, and my current position is at the Minnesota Department of Education, specifically in the Coordinated School Health Program. My professional background, both in education and training, is both in public health nursing and in elementary education. And the work that I do currently is a bridge between those two things, because we certainly know that health and education go hand in hand, and that's one of our best indicators of the health of the public is the educational level of the citizens. The public health background, I think, came after many years in working in healthcare and seeing the results of chronic disease and wanting to do more work around prevention. And so I went back to school and have kind of been working now in the prevention of chronic disease and other risk factors for many years. And the Coordinated School Health Program that the agency operates originated in the early, or actually late 1980s, early 90s, out of the Centers for Disease Control and Prevention, and really is a model of looking at all the ways in a school that students are impacted by health issues and trying to coordinate them for better health and academic outcomes for students.
I just wanted to clarify for the students now, the Coordinated School Health Program is about not just classroom education, but also services, health services in the school, is that right?
There are actually 8 components to the model, and it really incorporates everything in the school as well as community and family engagement. And so it really, as you said earlier, is around this model of it takes more than just one entity to assure the health of the population. So it's schools working with the community, with families, and then within the school system encompasses school health services, health education, physical education, nutrition services, counseling services, and as well as staff wellness. So
Thanks
it's
very
a
much.
comprehensive model.
And I'm sure we'll hear more in the second half.
Okay.
And Representative Huntley?
Yes, I'm Tom Huntley. I'm a state representative from Duluth. My background is I was a medical school professor at the medical school in Duluth, and I'm a biochemist, not a physician. And I retired from that in 2007. In the legislature for the past prior 4 years, I was chair of the Health and Human Services Finance Committee. Obviously, there was a change in the last election, so I know the Democratic lead on those committees. And that committee is responsible for about a third of the state budget. Almost all of that money goes to either people in nursing homes or people with disabilities. The other expenses are very small. For instance, the health department in the state gets about $70 million of state money The Human Services budget is more like $5 billion a year. So it's tough to try to get people to focus on public health since it's not that big a part of the budget. But we do know that your health status is about 10% of your health status depends on the health care you get. The biggest portion is your genetics, and the second biggest one is the environment that you live in or how you live, that sort of thing. So it's very important for your health status that you do the proper things, like get some exercise, don't gain a lot of weight. Those make very large differences in your health status. We did fund in 2008, we passed a very innovative bill, got a lot of national attention for cost containment kinds of things in healthcare, but it also included money for a program which we called the State Health Improvement Plan. And we spent about $47 million over the last 2 years on that. And that's money that goes to local, primarily county public health agencies. And they all, I mean, they're held very accountable, but in my particular part of the state, the 4 counties got together and did it jointly, and the biggest thing they did was help small businesses set up wellness programs for their employees. Big corporations, about 75% of big corporations have wellness programs for their employees. Small companies obviously have a little more difficulty setting those up, so one of the programs was to help small employers set up wellness programs for their employees to sort of fit in with what the big corporations can do.
Thanks. I remember years ago in graduate school the figure that out of every dollar that we spend on health, 4 cents is spent on prevention, and 3.5 cents out of that is passive prevention, such as immunizations, and so it doesn't require any action on the part of the. So that leaves 1/2 cent on health promotion, health education, for which you said I think is 80% of your health, something like that.
About 10% of your health status depends on the health care that you get from healthcare providers. The other 90% has to do with other things. Right. But we spend probably 95%
on the
money on that 10% of the effect.
Thank you. Mr. Schaefer?
Yes, my name is Matt Schaefer. I am the Government Relations Director for the American Cancer Society's Minnesota region. Since 1913, the American Cancer Society has been focused on both research and mission delivery, trying to find a cure to cancer, which is the #2 killer in the nation, but actually the #1 killer in Minnesota. We have our work cut out for us. Our business is broken out in 2 wings. #1 is research. We're the second highest research donor for cancer research, second behind our business partner, the National Institute for Health, NIH. In addition to that, we also offer mission delivery, and a lot of that focuses on public health, care coordination, working with providers. And my role in that is advocacy. Because one of the things that happens as research, you learn more about a disease, and we know when it comes to tobacco use, 30% of all cancer cases can be attributed to tobacco. 30% of all cancer diagnoses can be attributed to obesity. That's a newer science. I think that number is probably higher because we're still learning more about that. Our third aspect is access to care. Sometimes it takes a public health organization to state the obvious, but if you're diagnosed with cancer, you have a much greater chance of survival if you seek medical treatment for it. And unfortunately, one of the things we're seeing across our country is there are a number of folks who are declining treatment because of cost. And that's a big problem, particularly when you're trying to cure disease. And #4, and last but not least, is continued research, because there's still a lot that we don't know about cancer, and we can't do it alone. And the National Institute of Health, the NIH, has been offering grants since the Nixon administration, and we want to make sure they stay at the table. And I should mention, in terms of public policy, I do want to give credit where it's due. Another very meaningful piece of legislation that was passed in 2007 was carried in the House by Representative Huntley, and that was the Freedom to Breathe Act. And in terms of public health successes, I think we have to kind of point out smoke-free bars and restaurants are going to have a far more significant impact on the health of our communities than a number of other incremental changes. This is big, and obviously Wisconsin has followed suit. Last year, South Dakota followed suit. Iowa is also smoke-free, so really our border states have really kind of taken Minnesota's lead, and I give a lot of credit to the gentleman to my left for really getting the ball rolling on that.
Oh, we've come a long way since the 1950s on smoking.
Mm-hmm.
Thank you, and that answered one of my questions: is how does the National Cancer Institute and how do the National Cancer Institute and the American Cancer Society fit together? And they do work together then.
We do work together in terms of research, and when you look at our research grants, the American Cancer Society invests really in, I would say, younger researchers who are just beginning their careers. A lot of folks will see their first couple series of grants provided by the American Cancer Society and the NIH. And this is a broad statement. There are certainly exceptions, but we'll tend to make contributions to research for those researchers who have come along and they've been carrying out their projects. And obviously clinical studies or clinical trials are a huge area of research where we make a number of contributions. But and a lot of that's really, our research dollars come from donor dollars, from the Relay for Life, from other programs that are seeking to really find a cure for this disease. So we look at them as business partners. They obviously write a check, larger check than we do, but we need them at the table, and that takes a lot of work.
Right. Oh, Mr. Jaker.
Hi, Jerry Jaker. I'm Executive Director of the nonprofit Minnesota Institute of Public Health, and MIPH. It's located in Mounds View, Minnesota. It's 40 years old, and it has been working as a consulting firm and a contractor to the state of Minnesota, 15 other states, the federal government, and a host of foundations and other people interested in helping with applied public health research with an emphasis on primary prevention. Been doing this for a long time, but like a few other people at the table, I came up through and into public health programming through schools. I was a teacher and principal, and my licensure is not as a public health administrator, but as a superintendent of schools. And kind of backed into the public health work by seeing, as Deb and others alluded to, kids at school are symptom bearers of other things going on in their lives, and started to say, somebody ought to be doing more about this. And so I became one of those people, and have most of my career been working on primary prevention, school and community connection. MIPH's vision is to be an innovative leader of bridging public health research with community practice. The knowledge of research with the wisdom of community practitioners, and trying to bridge that chasm that has taken a long time to bridge, I think. A lot of what we do in MIPH has to do with bridging prevention research and practice, substance abuse, mental health, nutrition, issues of the elderly, cultural competence training and adaptation of programs and practices, and to try to move that dial of best practices in prevention from some type of exception, some stellar exception in public health field, to a new normal where best practices in the community that are evidence-based are more of a norm and less of a kind of an astonishing shooting star that comes along once in a while. So that's what we are about. MIPH for the last 12 years has been a non-branded affiliate of Blue Cross and Blue Shield of Minnesota. So from an independent 501c3, we are now a 501c3 that has their own separate board and cost center and Form 990, tax reform, all those kinds of things, our own building, our own mission. We don't sell health insurance at MIPH, but we're detecting with the movement in the country of people looking at, for every dollar spent, 18 cents of the gross domestic product is spent on some form of health care, health service, that we're seeing kind of a sea change in the industry that we find to be really exciting. And you see, the Affordable Care Act and other things we'll probably talk about later is inviting, if not nudging, health insurance companies to be health companies and not just adjudicate claims and figure out how to deal with people who are hurt and are trying to get their health bills paid, but to be something of a leader in the primary prevention and wellness promotion for a number of reasons, cost containment and the value of an enriched life. And so the primary prevention is our purpose and our focus, and we work with a lot of schools and communities throughout the Midwest and more throughout the country.
Yeah, that's very helpful. Was I just for clarification, reading between the lines, and that cost benefit would be part of your research in order to, let's say if it's a government-supported program, convince the public or the legislature that for every dollar spent on a public health program, you might get $2 or $3 back if you look at the big picture?
Right. There's a lot of public policy and the stakeholders, I think, convert the value of health improvement with the return on investment. It gets translated into what do we get back for the money that we put into it. And I think that's a good part of it. In fact, it's a fairly a very valid question to ask, but it's not the whole picture. You also hear about social return on investment, not just financial return on investment. And that's not to dodge what is the value that we get for a dollar spent. I think it's a very valid thing to ask in this era of precious limited resources, is what do we get for our money? But if we talk about cost containment and cost savings, which is part of what MIPH does, Arthur, I think we also not just talk about cost savings, but cost value. If you went to the grocery store, if I sent you to the grocery store and your objective was to save money, one thing you might consider is don't go to the grocery store. You save all that money. There's a downside of not getting things that you want to purchase. But there is value that you can get depending on how you plan that trip. Do you clip coupons? Do you have a plan for how you're going to use and add to your nutrition, et cetera? And there's a value element that is parallel, but not the same thing as simply how much money can I save. That's from my end of the swamp. That's how we view return on investment, cost savings, and added value, and enriched life by health improvement.
Yeah, good way to look at it. Mrs. Carlson-Guest.
Well, Carrie Carlson-Guest. I'm the communications officer for the American Red Cross Northern Minnesota region, which is about the top 2/3 of Minnesota now. My background comes from, I am the daughter of an emergency room nurse. And so I grew up pulling over to the side of the road to help people and grab the, she's like, wait in the car, grabbing the gloves. And she was also the one who did a lot with organ and tissue donation. And so there was always a health dialogue happening in our house. And then I went on to, after my own heart there, study biochemistry and fell in love with it, and ended up, strangely enough, at an advertising agency and then at a public affairs firm, Hindley Horner, and had long-term care clients, Blue Cross Blue Shield, Quit Plan, and it's something that, and I was also had some health challenges when I was younger, so this is something that's very near and dear to my heart. I joined the Red Cross back in 2001 as a volunteer to try and be part of that public response and be part of that, and I was a disaster responder. And have been with the organization ever since. I fell in love with it. As the joke goes, it kind of got in my blood. But the American Red Cross is something that is part of the International Red Cross and Red Crescent Society. We are part of the largest humanitarian organization in the world, which is incredible, and we're led by volunteers. And that is that what we do is to support the work of the volunteers. So just even in our region, for every full-time staff member we have more than 50 volunteers. So it's really the community that's making this a priority and helping to respond in a number of ways. specifically going back to our mission, which is to help people prevent, prepare for, and respond to emergencies. And that emergency may be that a tornado has hit your home. It may also be that a family member has a heart attack, and do you know what to do? And educating people about AEDs, and working with children to teach them healthy habits, and also, what are the 2 ways to get out of any room, and the kind of ubiquitous stop, drop, and roll, and making sure that that prevention piece of it and preparedness piece of it is really there. The 5 pieces that the American Red Cross does, our core services, are sort of the first 2 that everyone knows, the 2 sides of our house, which are blood and flood. So flood being the disaster services. You've all seen, as of whether that's hurricanes or tornadoes in recently in North Minneapolis, and that goes all the way to we were helping people prepare for, and we're going to be part of the response with the pandemic. And so we're kind of involved no matter what that emergency is. We've been involved in that. The blood part of the house, we are collect more than half the nation's blood supply, and are incredibly honored to be part of that. And that's, again, part of the infrastructure that helps support our community health. The other pieces that we do, we support international services, which includes tracing, but a big piece, if you read about our measles program internationally, and so it's a lot of that proactive piece of it is working with vaccinations and inoculations. We have services to armed forces, which is now, we're the only organization that's authorized by the Department of Defense to relay messages to family members when they're to service members when they're deployed from their family members, and that's kind of been historically what we've done. But now what we're seeing is the mental health side of that as well, and we're working with psychological first aid and working with families after deployment when they come home, when service members come home, and I mean that's looking at the direct effect that mental health has obviously on health, and what that does to a family. That's another piece of the puzzle that we do. But the last big piece that we're really involved in is our preparedness, health and safety services, which is the CPR, AED, first aid, babysitters training, nurse assistant training, and really speaks to that prevention, proactive approach. That every disaster, no matter what it is really a community response first. And so the more we can empower people to be able to respond themselves, the less we're doing on the reactive side and the responding side. And I would love to say there would, yes, you could say that, yes, there would be your vision is that there will be a day when there will be no cancer. I don't know that I can say that there's going to be a day when there won't be any natural disasters or man-made disasters. I would love to say that. I especially given the last couple of years, I don't think that's going to happen. It's just not possible. But what we can do is make people more prepared and empower families, empower individuals, so that does one person in every household know CPR and first aid? Are businesses equipped with AEDs? And make the community the first line of defense, so that when organizations like the Red Cross or our government partners get to the response part, that the community is really our partner, that they're taking care of as much as they can, and we're kind of picking up and doing the other part of that. So we're very much invested in this part of switching that from the reactive focus to the proactive. How do we help share, information and knowledge and wisdom through all of our partners and to the community, so that they are part of that response and they are taking responsibility for their own health and the health of their families.
I'm glad you emphasized that the Red Cross is not just reaction, but there's a lot of preparation, a lot of prevention. And in the education, it's not just first aid, but also safety and nutrition, babysitting, and things like that.
Yeah, and it's even in specifically in this community, it's also new needs for education are arising with multicultural communities that we had, for example, a chemical prevention class that we would go in and teach kids. Well, we had our Yahe, our Somali outreach coordinator, revamp the entire course because he needed to teach that in the Somali community they were using bleach to clean everything, and so that looks a lot like a milk container if you can't read the labels, and Comet looks a lot like Parmesan cheese. And educating kids, and by the way, if you're among immigrants, it's this is Minnesota, as we are all well aware, or Wisconsin if you're in this, in River Falls, and it does get very cold. And again, just those little pieces that when you mention, when you're talking about the environment and what people do every day makes such a difference. What are the choices that they can make to make sure that they and their family and community are healthier.
Thanks, and we'll look forward to hearing more about the Red Cross in the second half. Thanks. And Mr. Galt?
Hi, I'm Donald Galt with St. Paul Ramsey County Public Health. I manage the Healthy Communities section here that I'll tell you about in a minute, but our department, we are the local public health department for the Ramsey County community. We serve St. Paul and then all of suburban Ramsey County. Most of what our department does actually is provide services to the community, which range from things like environmental health, so the water that you're drinking is nice and clean and good. We can't take full credit for that, but we'll take a little bit. But we do environmental health services, we do family home visiting services, we provide a range of clinic services, we work in public health emergency preparedness in partnership with Red Cross and a lot of other organizations. We actually also, we run correctional health services for Ramsey County. One of the interesting things in the United States is, I believe this is the case, that the only people in the United States who actually have a constitutional right to health care are people that are incarcerated. It's kind of an interesting thing. So we provide very wide range of correctional health services to people in our correctional health facilities. The work that I do in healthy communities actually is not service related. It's much more, as Jerry was talking about, primary prevention related. And the work that we do falls into four categories. We do adolescent health promotion, which includes prevention of adolescent pregnancy and promoting healthy youth development. We do Hmong community health promotion. We have, I believe, either the largest or second largest urban Hmong population in the country residing here in Ramsey County. We do chronic disease prevention and have been working on the SHIP grant for the last 2 years and have done a lot of other work prior to that in that area. And then the fourth area, and the area that I have the most experience in, is actually violence prevention. And we have been working actually for over the last 20 years on family violence prevention and community violence prevention throughout Ramsey County. As I've been in this work now, well, I've worked here for over 24 years and I've been in public health about 30 years. And it's really interesting as we watch kind of like trends and changes in the field. And there have been trends and changes in the field that I've seen both in relation to the topics that are very high on the public's agenda. When I first started working in this department, actually the highest thing on the agenda was probably elderly health services. And then we moved into HIV/AIDS. And I'm not saying this cynically, as different issues bubble to the top, they come to the top. These days, really chronic disease and looking at issues around obesity and tobacco are very, very high on the public's agenda. And that is both an opportunity, but it's also really a challenge, because when we look at the kinds of work that we're trying to do, it can be hard sometimes to take fairly large, complicated issues and work on them for a couple of years and then move into something else. Which is why actually here in Ramsey County, one of the things I'm very proud and honored about is that our county board over 20 years ago decided we would dedicate staff based on basically our local public health dollars and put that into doing violence prevention work for 20 years. So we have not been dependent on grants coming and going. And in that time, we've really been able to move from thinking, boy, it would be nice to be able to do some primary prevention work around family violence, to actually being able to do it and doing work that we've been able to demonstrate actually has an impact now, which is really quite exciting in the work. The other change that I've seen over time, and I think it's maybe kind of a pendulum, is when I first got into this field on the health promotion side of things, the state of the art was health education. And, we had our little boards and we would go in and show people pictures of bodies and what is good and not good to put in them and stuff like that. And we were kind of over there, and I'm being a little facetious, but not too much. And now we've moved over to this notion of policy system and environmental change, which is really what the SHIP grant was built around, which I think is a really smart approach, because in part, the phrase that people use to describe what we're trying to do is make the healthy choice the easy choice, which sounds kind of trivial, but it's actually huge, because when we're talking about tobacco, when I learned to smoke cigarettes, I was working in a hospital in Evanston, Illinois, and we sat at the nursing station in the early 70s, and I was an orderly just out of high school, and we would smoke cigarettes while we were charting. And that's really where I became a really good smoker. I quit a long time ago, so you don't need to. And actually, even when I started working in this department 24 years ago, people smoked in the public health department main offices. And we have made, tobacco use not the easy choice anymore. So we've really done that around eating and nutrition. That's a really interesting challenge. I live in Roseville, right near Harmar Mall, and you just go up and down the stretch of Snelling Avenue there, and you can see a whole lot of choices that probably aren't the healthy choice, but they're definitely easy. So that's part of the challenge. The last point that I'd just like to make about that pendulum, though, is I think we need to get kind of back to putting both of those together, because I don't think it's purely policy system and environment change. I think that's really powerful to do, but at the same time, one of the things that we've really based our work on, and have based those 4 areas of work that I told you about on, is that it's our belief that you can make healthy choices easy for people, but people also need to have a sense of possibility and hope and purpose in their lives. And I think that when we ask the question, why is it that people end up making these choices and sustaining them over time, we can make them easy for people, and that's great. But people also, if you're kind of looking at your life, and we've all been reading about what's been happening with the children being murdered in Minneapolis. And I really like to be careful about the language we use, because we always like to throw in, well, it's North Minneapolis. Well, I don't live there, so I guess that's not my problem, and it's them. No, this is our children being killed. And I would suggest that a huge part of why that is happening is that many, if not most of the people involved in that horror today really probably can't look and say, this is my plan for the future. This is what I want to do. And so a huge piece of our work is really trying to build that sense of possibility and hope in people's lives, so that they can make these healthier choices in their lives.
I appreciate that. I didn't really have a guest from the National Institutes of Mental Health, but I've heard several people cognizant of that component of healthcare or public health. It's underlying some of the others that are more at the surface.
Yep.
Well, thank you. That was a great introduction. Now that we know each other and the students know you a little bit better, I thought they'd be interested in your idea of just what community health is. We spend, the nation, I think that health expenditures are second only to defense in this country. A huge portion of the gross domestic product, I don't know if it's 13, 14%, something like that.
16.
Is it 16% now? And I would suppose it's going to grow. And the students are probably familiar with personal health care. They know about going to the doctor, or if they were at school, there was a school nurse. Community health might be a little bit harder to visualize, so I just thought that each of you might, in no particular order this time, just give your perspective on just what community health is and how it fits in and why we need it, or do we need it?
Well, one of the leading reasons that people get admitted to hospitals is food poisoning, and the Department of Health is responsible for inspecting restaurants and making sure that they do the things you're supposed to do to make sure that people don't get food poisoning. So that's just one. They do a lot with vaccination. Probably the most cost-effective thing you can do in medicine is vaccinate kids. And the other thing, we have a very good state health department. I remember in about mid-90s, there was a meningitis outbreak in Mankato. And they went down there, worked with the local public health nurses, but they vaccinated something like 15,000 people in, I think, 4 days.
Excellent.
And so that was a response to something that could have turned really bad, but they sort of held it down.
And they were able to do that because they were ready. They were set up for it. So.
Right. Arthur, you mentioned what our national expenditure is for health care, and I'm not sure your students would know that even though we spend more than most any other place in the world, our health outcomes are not as good as those places. And I think the community health piece can help fill out some of the piece of why that is, that it's not just about access and the health care that you're getting, but also the environment that you live in and the choices that you make. Some of the conversation about the pendulum swing and the combination of health education and community health around systems, policy systems, and environmental change, to me kind of resonated with the concept of health literacy. And really what that's about from the educational world and the healthcare world is that people understand enough about their own bodies and staying healthy, what to do for prevention, but also understanding the influence in their environment. In childhood obesity right now, one of the big issues is around marketing of unhealthy foods to kids. You've probably all heard the study about, kids less than 2 years old can identify McDonald's as a business and as a place they want to go. And in our state currently, we don't even have health education standards for our students in K-12.
That's true. I know that because I've taught health education.
And we are one of the few states that doesn't have them. Just in the 2010 legislative session, we did institute physical education standards so that we're catching up with the rest of the nation there in terms of at least standards around physical education. The health literacy, I think also in healthcare, I've worked on initiatives around the costs of staying healthy, and if the patient doesn't really understand the instructions given, they don't follow through on what the prescription or recommendations are, they're often either rehospitalized or not making the progress that they should. So I see that as really, we do need to really work on changing the environment to make the healthier choice the easier choice, but we also have to do more around educating our citizens and our young people in particular about understanding how health works, and so we're more focused on staying healthy as opposed to treating disease.
I would say too that, when I think about the community health, the old phrase that comes back into my mind is the crown of health is worn by all but seen only by the sick and injured. If we're well, we take that for granted. And I think the society and the times and the community environments that we lived in have changed. My grandpa never scheduled time to go to a gym. He didn't have to. It's just how you worked and what you got done. He didn't belong to a gym. It has to be kind of a conscious choice in today. And I think the community health part is what do I need to know? Where do I get accurate and current information about tobacco, obesity, violence, the decisions regarding sexual behavior? You pick the topic. What do I need to know? Secondly, what do I need to be able to do? Where do I get skills training and to figure out not only what do I need to know, but what do I need to be able to do to get out of a risk situation, to say no when I mean no. And then thirdly, where do I get support from that? Whether it's laws, ordinances, rules, family norms, you pick it, the written and the unwritten rules of what's okay and not okay. And so I think the community health piece is, how do you do what do I need to know? What do I need to be able to do? And where do I get support for doing things healthy? And proactively, intentionally, because it doesn't happen like in Grandpa's day. We have to kind of work at it because the environment we're in is not as conducive to health as we might think. And the only people that really, really get that are those who have been sick and injured. So other than that, we have to make sure that we don't present health promotion and primary prevention as fun and games. Because who is for obesity? Who is for violence? Who's for tobacco use or excessive alcohol use, etc.? Our enemy isn't opposition. Our enemy is being patronized in prevention. A little tap on the head. Do your red ribbons and blue balloons, and good for you. Here's $5. That kind of thing, where we're talking about an absolute sea change in how we approach health, and there's an intentionality about improving our health and getting support. That's where the community piece comes in, is if I take better care of myself and those I care about, where do I get the support and the impetus to keep doing that and to be intentional about doing it? And what's the payoff for me and my family in terms of an enriched life and my community?
And I think that goes back to what Donald was saying earlier around violence prevention, that people have to feel good about themselves and have motivation to want to do better. If their life circumstances are such and they're in a poor environment that doesn't support that, then there's no reason to make the healthy choices because they don't see themselves living beyond a certain point. So it's that community piece that provides a strong support.
And I think there has been a whole shift too in community health, and you can see it sort of incrementally from, as I mentioned earlier, from prevention or from response to prevention. And you look at every environment that people are in, whether that's in schools, what's changing in the vending machines, or grocery stores, and now all of a sudden you see the big marketing thing is no high fructose corn syrup. They're promoting that. This is a good thing. And now, just even this week, hearing that Fairview hospitals are shifting the way they're going to compensating doctors, not based on the number of patients they're seeing, but on surveys and health outcomes. So it's more of that Eastern philosophy of you basically get paid to keep people healthy. You don't get paid when they're sick. So if they're sick, you did something wrong. And so, but shifting that whole, whether that environment is the doctor's office or care provider's office or a school or their work, I think it's that whole paradigm shift of, we're not going to wait till there needs to be a response. It's the prevention side of that. And we see that in the Red Cross locally and also just internationally in the millions of children that have been able to be vaccinated with measles, for measles, and how many lives that saved. So I think that, incrementally you're seeing, that culture change of, what's considered normal, what's considered acceptable. Well, it's, now that no one, can smoke inside, it's, if you go somewhere, like my husband is from Oklahoma, and you go in and all of a sudden you walk into a restaurant and they say smoking or non-smoking, and I, really? There's a choice? And it's not really a choice because the ventilation and it, but I think that once you get used to it, you can't imagine it not being that way, or and they said you used to be able to smoke on airplanes. You can't fathom that now. What do you mean people could smoke on airplanes? And so I think that it is a community response. That is the community health. It's the community responding and changing the culture to make that huge shift.
I think it's a partnership. I mean, earlier Donald alluded to the point that there were really two focuses: community health and personal responsibility, and they really have to be married together. Health reform has been something that's been discussed for the last 5-10 years, well, longer than that, at the state, federal, local levels, but you really can't talk about health reform without a community component. Smoke-free bars and restaurants are a perfect example. Within the first year of Minnesota's passing a smoke-free bill, quit lines experienced an unprecedented increase in the number of people seeking help for quitting. We saw statewide a decrease in tobacco use over the past 4 years. It's been about 4%. It's kind of tapered off. We know that the other incentive that will get someone to quit smoking is price. If you increase the price of tobacco products, anytime a legislature uses a tobacco tax increase to help balance their budget of at least 50 cents or more, they've tracked it. The quit lines, the plans, the hospitals, anyone who's providing a quit service, the American Cancer Society sees a tremendous jump in the number of people saying, okay, how do I quit? Give me some help, give me some support. So we know that there can be environmental changes, and that's why from our organization we continue to push those. The bigger question now we're all looking at is obesity and the community changes there, and I think it is going to have to be a partnership. Number one, consumers need to be armed with the information they need to make better decisions. There's been talk about, I know there's a couple different metrics out there, like assigning a score from 1 to 100, which I think is a little broad. Maybe stoplights would be a little more understandable. Red, green, and yellow. That's one start. But I mean, it has to be a partnership. It has to be giving people the tools they need to make the right decision. Cost is a sensitivity issue, and really I think that's the community environment. And the question is where that line is. How much can the community do to get someone to the place where they can make the right decision?
And that part that you're talking about, that easy, I love that, where you're saying the healthy choice is the easy choice. And
I didn't make it up.
But in that, it's now with the influx of technology, it's how do you communicate with the community? For example, one of the things that we're doing at the Red Cross is we have an app that you can download on an iPhone and an Android, and it literally walks you through step by step. Is the person breathing? Yes or no? And it goes through burns and first aid and all of that. So it makes it easy. It's not, I have to I got to give up my Saturday and I got to go take a class and, it's going to be boring and all that, and I'm never going to use it. Whereas if it's just on your phone and almost, we're finding almost everyone has a phone, and that's going to continue. That I think that's going to be a shift that the students in community health are going to see too, is how do you share that information? And not just on the prevention side, the response side, we're seeing when disasters happen, when emergencies happen, social media is a huge tool to let people know you're all right. People are going, maybe if you can't get through on a cell phone, you're going on Facebook. We have digital tools to track whether or not people are safe and well. So I think that that's going to be a huge component of what people are going to be looking at, and how do, their tools in the toolbox. How do you use those tools in the toolbox to best affect the change that you want? But I think that's part of that community, because that's what social media and a lot of that technology is that it provides a community. And now you see things like on Facebook, there are people that put the little a code message or whatever that goes viral about about breast cancer or something, and what size they are, bra or whatever, and it's a joke, but that's how to do something on a sunny day, is that goes viral then, and all of those people in the course of their day now just heard about breast cancer, and we're talking about it at work because did you get that funny thing, and and it also might make the news that night. So I think there's a whole uncharted territory too about how do you communicate this and how do you engage people in it, and make it that easy choice. So that part's exciting to me, because I think there are some really amazing things that can be done.
I could follow up on easy choice, since we're all doing that, but when I'm a little older than most of the people on this panel, and when I was a kid, when you graduated from grade school, you put your bike away and you never rode it again. And
Really?
you look at
Wow.
what's happening today with bike trails. Makes it the easy choice to go for a nice ride on your bike and not worry about being killed by a car or a truck.
Right.
And that was a conscious decision made by a number of people to put these bike trails in. And it's been, there's one goes along Highway 35 that I ride up Highway 35 to Duluth, and you just see entire families out riding their bikes. And that is certainly a change from what it was when I grew up. Now, last week I was in Berlin for the week, and we have a long way to go on bike riding to catch up with them. And they, as a society, are, at least in northern Germany, thin because they just choose to be thin. And someone once said that obesity was a communicable disease because you look at somebody that's obese and you look at who their friends are, and it's pretty interesting. And we need to change that attitude so people think that being thin is the way to be.
Well, in regard to the various theories, whether it's genetic or environmental, there was a study in London that showed that the pets of obese people were obese.
My sister used to have, when we lived, I'm from Chicago, and when we lived there, I used to take care of my sister's dogs and her cat, and she had this cat that weighed like 20 pounds. It's this huge cat. And when we would take care of the cat, she would always say, well, give him 2 bags of this food. And so I would look on the bag of food and say, serving size 1 bag a day. And I said to her, well, why are you telling me to give him 2? And she said, well, because that says for an 8-pound cat, but he weighs 20 pounds, so you have to give him 2. No, I'll never forget that one. I want to talk about a couple things that I think we need to do better in public health work, because, and it relates to your question about how do we get support and understanding for what we do. One of them is, I think we need to be smarter about the way we talk about what we do. And I can only speak from a local public health standpoint. I know you guys are really smart because you're communications people. But seriously, I think a lot of times we frame the issues that we're looking at and say, well, like let's talk about obesity, for example. And a lot of the public discourse is this is this huge, complicated problem, and it's going to take generations to change and all this. And I think, Representative Huntley, your experience in Berlin last week tells us there's people right now, not that far away, that are living differently. We can do much of this right now, and I think we need to frame the way we talk about our work. While yes, there's long-term things that need to change. For example, in our violence prevention work, we've been investing for 20 years in doing family violence prevention in Ramsey County. If you ask me the question, have we reduced family violence in Ramsey County, there's only one honest answer I could give you, which is I don't know. I really don't know that. However, here's what I can tell you, is we have done targeted work in a number of different areas, one of them being working to reduce the harsh treatment of children in public places through something called the Wakaisia Project. And I can tell you, and I'll come and testify, and you can look me up like this, it works. By making very simple changes in environments and organizations and the way people approach working with parents and children in public, we have been able to demonstrate over a sustained period of time with no money involved in this, in places ranging from children's museums to libraries, schools, clinics, that we are able to reduce over a sustained period of time the harsh treatment of children in public places. Our belief, and this is the part I can't prove, but the hypothesis would be that by doing that, if people have a good experience when they go into a grocery store or into a museum with their children, they're probably more likely to come home and have a pleasant evening with them than if they've been shamed and humiliated by the organizations and people around them. So, but we need to be able to articulate that and not try to claim things that we can't claim. There was a great article in the Pioneer Press yesterday about there's been a relatively low number of homicides in St. Paul this year. I don't know if any of you read the article. It was absolutely fantastic because they were interviewing the chief of police, and he said, yes, there's been a very low rate of homicide in St. Paul, and these are the things that we're doing. We're doing community policing, we're doing organizing, we're connecting with young people, we're doing all these things. What he did not say, which I think was very smart, is this is why there's a low rate, because we don't really know why there's a low rate is the honest answer, but these are the things we're doing, and they were very tangible and powerful. The other thing I think we need to be really careful about is not, and this, it's related, but it's not making the issues that we're dealing with too complicated. And we very often do that. And again, in this work that I mentioned in our Wakainja project work, by giving people very simple things like, frankly, smiling at people when they walk in the door and making sure that you have something for children to do when they come into your clinic, we're able to change what happens in those places. And you know, we can get very esoteric and large about these things, or we can say, here's what you can do. And what's so wonderful about, I was in a conversation with someone the other day about Mothers Against Drunk Driving. And you can look at Mothers Against Drunk Driving, you know, from a lot of different perspectives of why it's been successful, but a huge piece of it is because it has given people something to do. My son, who's 24 years old, he knew, I don't know why he knew this in high school, you have to have a designated driver. And it's just, they knew it. It's something that you can do, you know. We still have a huge alcohol industry. We have all these issues we might want to deal with, but people know designated driver. We need to give people similar things, you know, a call to action around riding bikes, around choosing healthy choices, and we need to make sure it isn't too complicated and that we're not telling people this is going to be really hard for you to do. I will say respectfully, I think we need to be really careful on the tobacco side to not make too big of a point of that it's hard to quit smoking, because the more times you tell people that, I think we make it harder for people to quit smoking. And we have to, you know, we have to be honest about it, but we also don't want to say, boy, this is going to be really tough, because then I think we've reinforced it. So
I think too, Don, our message in public health and prevention has got to be about clear, human, actionable steps.
Bingo.
I think what we tend to do in prevention, if we're not careful, we look like we're out to prevent fun. I have 5 children. They think that anything that is interesting, curious, somewhat entertaining, or maybe a bit of an adventure, Dad's going to find something wrong with it because he's in prevention. And so when we take the data and we try to explode on people who have other things to care about besides our issue, we end up admiring the problem and removing hope.
Yep.
We say, we know how much, how often, and how come this thing happens. And it's bad, and it's serious, and it doesn't look good, and have a nice day. You know, and what we have to do is make sure that we don't prevent hope, and we don't prevent fun. Health promotion can be interesting and fun. I spoke a minute ago, I sound like I'm a guy who doesn't like red ribbons and blue balloons and everything. I think that's part of, you know, the celebration of health, but we have been defined by that. We have been kind of minimized in prevention and public health, and in not using evidence-based and research-based and environmental change strategies. And if we're not really careful, we could write an environmental health curriculum for elementary kids that will basically be technically accurate and remove every shred of hope that those little darlings would have that the world is ever going to get better.
Yep.
So we have to say, and here's one thing you can do to help make a difference.
Exactly.
I couldn't agree more with that, and I think we have to remind ourselves we're not out to prevent and enrich life and fun and humor. We have to have some level of call to action, evidence-based call to action based on good data, but we have to make sure that it's inviting and that it kind of people can fit it into their life and not just kind of have to stop and feel like they're being lectured at of how they're doing it wrong and how they're going to die.
Exactly.
And I like that about the it's shifting the energy from no to having, you know, and I love the Do campaign about, you know, showing the guy he's dancing, you know, he's rocking out, and you know, I do that at home with the kids. So if we do that for half an hour, that's actually movement. That's exercise. It's not, you're going to have to go down to a gym and you're going to have to sweat and it's going to be painful.
Yeah.
You could take an amazing bike ride and see beautiful parts of the state and spend time with your family, and that's part of that. And you know, it's also it reminds me of a quote from Mother Teresa, and I don't mean this as a political statement one way or the other, but it's, you know, she said, you know, if you have an anti-war rally, you know, don't invite me, but if you have a peace rally, I'll be there.
Yep, exactly.
And so it's talking about, you know, what do we hope that outcome is, and putting that out there as instead of what we don't want.
Right.
So I think
What are we
that's a
for,
really good
not
point.
just what are we
yeah,
against?
exactly. What are we for?
If we
So-
did it all right, what would success look like? You know,
Exactly.
I think we have to profile that for people we're trying to work with at the community level.
If I could just toss in one thing, because I don't mean to monopolize, but as we were approaching our SHIP grant, we were just finishing, we had something called the Steps to Healthier U.S. grant. We had worked on that for 5 years, and we were getting to the end of that and wanted to figure out what could we do to create something sustainable, to promote, and to try to do exactly what you're talking about creating like a vision and a possibility of hope. And we brought together a very diverse group of people from our community, and we asked the question, what do people need in order to seek and sustain healthy behaviors? And the response we got back, and it was across the board from a very diverse group of people, was a sense of possibility and hope, that there was something that they could do. And we actually worked, it's a long story, but we worked with a very creative group of people. We used music, we used theater, we used images of the outdoors, and we created something called Exercise Your Right to Feel Better Minnesota. And it's a really powerful message. You have the right to feel better. And not to brag, but actually we won the U.S. Department of Health and Human Services Healthy Living Innovations Award, and we'll be getting that next month for this. And it's a it's a totally positive message. And a part of the message is, to be clear, we're not telling you, what your body type should be, what you should look like. We're saying, what would you like? What would help you feel better? You have the right to feel better. And that's, again, I think where that intersection between changing environments and personal choice comes in. It's your choice to do this, and we're going to make it possible for you by just even reminding you, you have the right and the possibility. You could feel better.
Well, and I think that messaging thing is huge. I mentioned earlier about the marketing to kids, and I think I've heard a statistic that all the money in public health that goes into kind of promoting quality of life and kind of be active, all those healthy messages, all that money, if you compare it to what the food industry spends on kind of putting forth food that's not so healthy. The public health expenditure, if you looked at a calendar year, all the money would be spent by like the second week in January. And then the whole rest of the year is the funds that is competing messages. So my point is really that I think in public health we need to be smarter about using what we know from marketing and communications to put forth positive, what you can do sorts of messages on staying healthy, as opposed to don't.
Yeah, on a positive note there, if you can just convince obese people to get some exercise, don't even talk about losing weight.
No, exactly.
If you can just get them to get some exercise, most of the health bad effects caused by obesity are greatly reduced, just because they're in good physical condition, even though they're still obese.
Yep, exactly.
I'd like to conclude on the note, just to take Dr. Jecker's note about giving an easy and appealing recommendation to the target population, to raise that up one notch for our listening online audience. Is one recommendation that we could leave our health and wellness management students with, and I would start by saying that we shouldn't assume that, let me say this, that I hear the president talking about consensus a lot, but it doesn't seem to be a very popular topic these days, and we shouldn't assume that we cannot get both sides of the aisle to agree on everything that we've said here today. I think it would appeal to both. For example, the WIC program, which is a maternal child health program to prevent birth defects and so on, has enjoyed continuous refunding, and it's been funded, I think, since the late 70s. So I think that a lot of these things could be acceptable to both sides. And so what I would recommend for our students is that not so much for personal health, but for taking good health care of the community, is to keep in touch with political candidates and public officials to bring their influence to bear to improve the health of their community, which could be the state or the nation. But I thought others might have one little tidbit to leave with the health and wellness management students. if anybody has
On that
something.
note, I'll just say in every school that participates in the National School Lunch Program, there is a requirement for a school wellness committee that really is about engaging the community outside of the school to work together, and what a great opportunity for anybody in the community, they don't need to have children in the school, to be involved in making the school a healthier place and having healthier options for students.
People talk a lot about the public health approach, and I think that's a real difficult thing to get heads around. For me, it means three simple things. Public health approach is first, be data-driven. What does evidence permit us to understand about the problem? Secondly, multi-sectors of community. Mention was made earlier about partnerships and public-private, and not just the usual suspects, you know. People in media and business and enterprise and faith communities, the whole 9 yards. What makes up community? They have to be part of the solution in a public health approach. And the third is, this is our wheelhouse, emphasize primary prevention. Evidence-based primary prevention. That's a public health approach. Data-driven, multi-sectors of the community, and primary prevention. And then I think we have a reason for hope and cause for hope.
Thank you.
I would say you talked about communicating with your elected officials, and I think sometimes in the public health world there's a temptation to write off one of the particular public party or political parties, and I would say don't be so quick to write off your legislator because, well, I didn't vote for you and you don't really share my same ideologies. I would challenge people to say, really take a look at what's important to that member and what's important to their party platform. One example we found with the SHIP program this year, there was a lot of arguments over its funding, and again, I think the results are going to be the same as yours, Donald. Did what we do work? I don't know, but we started looking at some of the SHIP programs' work site wellness activities, and started we took a look at Dakota County, which is a southern county in the Twin Cities metro area, and looking at some of the work they were doing, and we found two employers, one of whom really kind of implemented a smoking cessation plan, and 5 of the 20 employees who participated in the program actually quit. And then we looked at another program that took place at another manufacturer where they were actually revamping their campus. It was BF Goodrich, who doesn't make tires anymore, interestingly. I learned that. They make aircraft parts. Very fascinating. But they revamped their campus because what compelled it was they noticed that a lot of their employees were going down the street to KFC or to McDonald's for a lunch break, and it takes time to get in the car, drive out, eat, come back. So they built they wanted to build a better cafeteria, and they contacted the Dakota County Public Health, and through the SHIP program, got some consultation on building a better cafeteria with more culturally sensitive options. They have a very diverse staff. They also created walking trails, and these folks weren't doing this out of the kindness of their heart. They were doing it for the bottom line, and that's what compelled it. And so the question that we asked was, all right, I'm not asking did you see any of your employees lose weight. What's going on with your bottom line? How much productivity are you getting? How many aircraft parts are your employees able to manufacture? And they said, it went up. We're bought in. And so when you're communicating with elected officials, challenge yourself to figure out what's important to them. And don't make it about you because you're just one voter in a community. But if you can make it resonate with them, that's going to go a long way. We talk about running trails and bike trails. I live in what's considered a Republican district, although when you look at the way the city's designed, it was interesting. When we moved to the Twin Cities, one of the things I forced my wife to do was let me go to City Hall, and I gave a little test. I said, hey, can I see a map of your bike and running trails? And there were some cities that looked at me with a blank stare, and they were promptly fired. And there was one that actually said, yeah, let me show it to you. He pulls out the trail, and he started showing me all the good biking trails and all the good run routes, and that's the city we live in. And I tell that story to the elected official over there and say, so don't be too quick to say SHIP is bad, because this is one aspect of the program. So don't just communicate with your elected officials, but do some research on them. Figure out what's important to them. Figure out what's important to their community and communicate to them. Are you going to flip a vote? I don't know. But if you're able to at least go in smartly rather than saying, hey, make love, not war, you're probably, you're increasing your odds for success.
Any other comments on this? I sort of picked up something from somebody. It was about how paying more and doing worse, something like that. And it's almost like saying, well, the free market is a good idea. It's the muscle, it's the engine behind the economy, but maybe it doesn't work so well in healthcare. And I heard the explanation that's because hospitals don't compete for patients, they compete for doctors, who then draw in the patients because of their reputation or whatever. But I think that, I think we could all agree that uncontrolled capitalism isn't a good idea, and maybe we're one of the controls.
Well, the trouble with the healthcare system is we don't pay for what we want.